anterior shoulder instability, and it could very much be different than yours, but I'll kind of go over the rationale of why I do some of the things that I do in my algorithm. So the first decision is whether to operate or not. And advantages of treating a dislocation non-operatively is that there's an earlier return to sports or return to work, and you avoid surgical risk. The disadvantages, and what I worry about, is redislocation and further damage to the joint. So in my practice, the non-operative treatment is only in first-time dislocators. If someone dislocates more than once, they're getting surgery. If there's no bone loss, they're not a contact athlete, or they have a low-demand job, older patients over 35 and 40 where the risk of redislocation is low, and there's no red flags on the MRI like haggles or Alpsa lesions. If they have to get back to sports and that there's a potential loss of scholarship or loss of income, that's also a factor. I can tell you that over the years, my practice has become to be more aggressive, even in first-time dislocators, especially in young men who are contact athletes. I kind of talk them towards surgery at this point. And what we worry about is bone loss. With redislocation comes further damage to the joint, and when there's bone loss, the risk of redislocation goes higher, so that's what we want to avoid. And so what is the critical bone loss? So how much bone loss is acceptable? I think that's a moving target, and the initial description by Burkhart and De Beer was at 25%, and over the years that percentage has come down, but it varies patient to patient. So a 17-year-old contact athlete who has laxity, 10% bone loss may be critical for them, but a 45-year-old who's a non-contact and has 20% dislocation or 20% bone loss, they may do okay with non-operative. So that number kind of varies depending on a lot of factors. And